And now we're going to move to another really another of the key issues in the pandemic, which has been the workforce, their working conditions. And in this case, we're going to look in particular at risk recognition policies for the long-term care workforce during the first year of the COVID pandemic. And this is a multi-study country. And I'm very grateful to Amy, Sue, and colleagues for putting this panel together, and look forward to learning from this. So thank you very much. All yours.
All right. Hi. Thanks so much. So I'm going to share my screen. And then just get it into presenter view. All right. You guys can all see that? Adelina, we're good?
We see the split screen. I don't know if you want to do it again as a slideshow, but if not, I think you can see it.
Is that better?
Yeah, that's right. Thank you.
Oh, okay. Sorry. Computers. Okay. Thanks, everyone. So I know we are a bit behind on time, so we'll try and keep this moving quickly. And if we don't get to questions at the end, you know, you can throw them into the chat. We'll also share our emails. And if there's anything in particular that we don't get to, you feel free to reach out. Happy to chat offline. So for our presentation, this is actually based on a paper we just finished. So I'm going to go through the background, our methods, then it's broken into two main sections. So compensating for added health risks, and that's a focus on hazard payment. And Maya is going to talk about that. Then I'm going to talk about protecting against added economic risks, and that's a focus on single site orders. Shereen is going to share a case study from the UK. Maude is going to talk to us about Quebec, all the way in Canada. And then if there's time, we can have a discussion, but I'm not sure. Okay, so a bit of a background. You know what, I think most of you know this, but so personal support workers, which is really the focus of this paper, are the lowest paid in the health and aging care sector. Many have multiple employers or work more than full-time hours across several facilities to earn a living wage. These precarious work arrangements experienced by many long-term care staff led to the creation of a shared workforce with high rates of staff turnover. And in the early months of the COVID-19 pandemic, the presence of the shared healthcare workforce among multiple long-term care homes was identified as a contributor to the spread of COVID-19. So essentially what we did is we conducted an environmental scan of publicly available policy documents and government news releases. And we did so between March 1st, 2020, and then up to March 31st, 2021. So that's sort of the first year of the COVID-19 pandemic. And we collected data at 2 points in time. So between March and June 2020, and then recently March and April 2021. And so our data collection included federal or national, and then of course subnational government or long-term care association websites. And we focused on information that related to wage supplements like hazard pay or single site work orders. And we limited it to government or public health policies. So anything that might have been an organizational or a corporate policy response, we didn't review these. And so the countries or jurisdictions that we included are Canada, the UK, Australia, and the United States. As much as possible, we validated all this information with experts from each of these jurisdictions. And then we felt that these countries were a good comparison. Why did we feel that way? Well, in all of them, there's a role, or there's an emphasis on subnational governments who play a role in regulation and financing long-term care facilities. There's, of course, a mix of public and private financing in all these jurisdictions. And of course, they're comparable with respect to workforce composition, and it's predominantly female workforce, median age of 45, and a reliance on foreign-born workers. Okay, so I'm going to hand it over to Maya to talk about compensating for added health risks.
Thanks, Anna. So my name's Maya Murmann, and I'm a research coordinator at the Bruyère Research Institute in Ottawa. And I'm going to be giving a quick overview of the financial policies that were introduced to compensate frontline workers for the added health risks that they've endured during the COVID-19 pandemic. Next slide, Anna. So hazard pay is defined as the additional pay for performing hazardous duty or work involving physical hardship. So previously, it was provided to workers in dangerous jobs such as mining, but it became a policy response that was used by some governments to compensate frontline workers for the health risks that they've endured during the COVID-19 pandemic. So by March 31st, 2021, the end date of our study, 11 states in the US, all 13 Canadian provinces and territories, Australia, as well as Scotland and Wales in the UK, had introduced some form of hazard pay that was available to the long-term care workforce. So these hazard pay programs took the form of either an hourly or weekly top-up, a percentage increase based on their salary, or a one-time lump sum payment. So few of these programs targeted long-term care workers exclusively. Rather, the intent of many of these financial measures was to compensate more broadly low-income essential frontline workers, which would then include some long-term care workers. Next slide, please, Anna. So while there were several proposals to implement a federally funded hazard pay program in the US, by the end of our data collection, none had been passed into law. So in January 2021, President Biden announced the American Rescue Plan Act, the ARP Act, which was a $1.9 trillion funding package. Although dedicated federal funding for hazard pay was not included, the ARP Act did provide $350 billion in state and local aid, which could then be used for hazard pay. However, it was stipulated that it could not exceed $13 per hour or $25,000 per worker. 11 states, which are listed on the slide, had developed their own hazard pay program. So though there was significant cross-state variability in terms of the eligibility criteria, as well as the amount of payments, LTC facilities were recognized as an eligible workplace in all programs. Next slide, Anna, please. So in Canada, unlike the US, there was national funding for hazard pay. On April 15, 2020, as part of the COVID-19 economic response plan, the government of Canada announced it would provide up to $2.3 billion to increase the wages of low-income essential workers across the country who face increased risks and to ensure continued operation of essential services. Though these wage top-ups were financed federally, it was up to the provinces and territories to determine which essential workers were eligible and how much they would receive in top-up. 6 provinces introduced hazard pay programs that were exclusive to health and social care workers. So for instance, in Ontario, the temporary pandemic pay program provided a $4 per hour top-up to all non-management long-term care employees, alongside a few other social service workplaces. The other 6 provinces and territories implemented hazard pay programs with more general criteria, inclusive of a broader range of essential services and workers. So in these cases, a low income threshold was commonly used to determine eligibility. So you had to fall below a certain income to qualify. So for example, in PEI, frontline workers who earned $18.75 per hour or less were eligible for a one-time payment of $1,000. The province of Alberta was a little bit unique in that it was a late adopter of the federally funded program, but they had introduced their own hazard pay program that provided a $2 wage supplement for healthcare aides in publicly owned long-term care facilities. Next slide, Anna, please. So similarly to Canada, there was a federally funded hazard pay program in Australia, which was titled the Workforce Retention Payment. And so this program provided 3 rounds of payments of $800 to direct care workers in long-term care. What was unique in Australia compared to some of the other programs was that it was explicitly intended to stabilize the long-term care workforce during the pandemic. Next slide, Anna, please. So Shereen will be giving an overview of hazard pay in the UK shortly, but as a quick summary, in the first year of the COVID-19 pandemic, hazard pay policy measures were widely introduced in Canada and Australia in recognition of the increased risks that they faced. In the US, these measures were limited to only 11 states during the first year.
Cool. Thanks, Maya. All right, so I'm going to talk about protecting against added economic risks, and here we're going to focus on single site orders. So why do we need to protect against added economic risks? So as I said at the beginning, some PSWs, personal support workers, healthcare aides, I know they're referred differently in multiple jurisdictions, but where I'm from, we call them personal support workers. So they often work for multiple employers or work more than full-time hours to earn a living wage. And like I said, we felt these precarious work arrangements may have contributed to the creation of a shared workforce, meaning these folks are working in multiple homes or between a long-term care home and a hospital. And in the early months of the pandemic, this was identified as a contributor to the spread of COVID-19. And thus they implemented what's called single site work restrictions in some jurisdictions. So single site work restriction policies sought to limit the movement of staff across long-term care homes, and in some cases, other facilities like a hospital, for example. And in some more extreme cases, maybe if folks worked elsewhere, like in hospitality, for example, or food services. So while the implementation of single site work restrictions appears to have had some success in containing the spread of the virus, they may have led to unintended consequences impacting the long-term care workforce and service provision by exacerbating staffing shortages and financial insecurities among workers. And what I mean by that is if you're working part-time at one home and part-time at another and casual at another, and then you're restricted to one home, that's not enough hours or income for you. So generally, with respect to single site work restrictions, there were 2 applications of a single site work restriction, or from what we found in our review. So it either indicated no movement between facilities was permitted, or movement was permitted within a 14-day time gap between periods of work at different facilities. So after our review, we found that there were no measures to restrict mobility of long-term care staff introduced in the US. So remember, that was from, looking at government, public health, federal documents. So perhaps a corporation or a specific organization may have done something differently. Single site orders were mandated or recommended in nearly all Canadian provinces and territories, the UK, and 4 Australian states. We specifically chose to use the language mandated or recommended because sometimes it was just delivered as what we felt was a recommendation, meaning it wasn't enforced. because these restrictions may have contributed to income loss for staff, a variety of financial measures were used to protect workers. So we place these into two categories of policy measures. So allowing staff to work beyond full-time hours at a single site, or maintaining or increasing their remuneration. And in some cases, these were designed to support staff retention as well. So, you know, because a lot of homes would have lost people. So what I'm going to do is I'm going to share with you a few examples. Canada was pretty complex because provinces and territories delivered these quite differently. So I'm just going to show you an example from Ontario and BC because they're quite different, and it will give you an idea of what happened in Canada, sort of. So this is actually copy and pasted from the Ontario order. And as you can see, I would consider this like a mandatory order, but with respect to how they were compensating or supporting staff, it's really just at the bottom there. Long-term care homes are encouraged to use emergency funds to bring part-time staff to full-time hours to meet staffing needs. And the reason I'm showing you this one is because when we go over to the West Coast, British Columbia, they made a lot more, they developed something that in my opinion was far more comprehensive and detailed. So in British Columbia, employees restricted to working at one facility would be paid the highest wage they received while working at multiple facilities. So if they received something lower in one, wherever they were, they got their highest wage. Employees previously working at multiple sites could work the total combined hours at a single site up to a maximum of 1.3 FTEs. So that's more than full-time hours. So if they wanted to, they could continue to work more than full-time hours. I'm not sure that's actually a good thing that we're forcing this workforce to do that, but nevertheless, they were given that opportunity should they want to. And yeah, like I said, this recognizes that many multi-site workers or PSWs work more than full-time hours to earn a living wage. So it's not necessarily a good thing, but they were giving them the opportunity to continue to do this because they need it to earn a living wage. In addition to these measures, from what we can tell, the British Columbia government introduced a centralized staffing approach, which ensured long-term care staff were paid a standardized wage and were employed on a full-time basis. So the provincial government decided to sort of take this into their own hands in some ways, and this is how it rolled out, which was different in Ontario. And of course, like I said, it varied across provinces and territories, but don't have time to go through all of them, but that gives you an example of something more detailed and something less detailed with respect to compensating staff. Then we move on to Australia. I won't discuss the UK because Shereen's going to do a far better job than me. But I'll speak to Australia before I pass it on. So although there was no national single site order in Australia, several states introduced single site orders after the first wave of the pandemic. So it's kind of hard for you guys to see, but there's little blue things like Victoria, South Australia, Queensland, New South Wales. That's when they introduced single site orders. And then the rest are the waves of COVID-19. So Victoria, which was the state that experienced the most COVID-19 cases and deaths in long-term care in Australia, was the first state to introduce a single site order on July 27th, 2020. And then they had subsequent single site orders. New South Wales was December 18th, and so forth. So this is sort of like a synopsis of what they did in Australia, but they had, what are these called these guiding principles. So these are updated all the time. That's just an example. I PDF'd one of them. The guiding principles were developed to assist long-term care providers in limiting staff employment to a single site within designated hotspots. So areas with heightened COVID-19 cases. Initially developed for Victoria, they were adopted by New South Wales and Queensland. A key component was to ensure that no long-term care worker would be financially disadvantaged. And you can actually see that on the PDF. So we didn't make that up. Accordingly, this required that sufficient payable hours be offered to long-term care workers to allow them to maintain their income under a limited number of circumstances where extra hours were unavailable. The primary employer would pay the employee their remaining total average take-home pay. So they got all their pay, even if those hours weren't available. Long-term care providers in designated COVID-19 hotspot areas could claim workforce costs, and this included costs arising from implementing single site work arrangements and supporting workers affected by the single site restriction. All right. So I'm going to give it over to Shereen so she can talk to us about the UK.
Well, thank you very much, Anna. I think I'm going to go very briefly here because we already heard about what's happening in the UK. So I'm just going to highlight the differences perhaps. So if you go to the next slide, I think one of the interesting thing about or differences in relation to the UK is its kind of mixed economy and also the relationship between social care and NHS. So one is free at the point of delivery, and the other one is really quite, which is long-term care, very fragmented, and have a lot of private employers. But also it's kind of delivered in different settings, care homes, you know, home care agencies, etc. Next slide. One of the interesting things that, you know, the evidence that happens that social care was almost absent from the policy agenda when COVID-19 hit. In fact, it was only brought into attention when problems happened and the relationship between hospital discharges and care homes. That was very problematic when it emerged that there were no kind of infection control strategy when people were discharged from hospitals to care homes. The workforce was almost neglected. The Adult Social Care Action Plan was published in April, almost a whole month after the countrywide social distancing. And then in May, there was an introduction of dedicated funding. However, it wasn't clear what the funding is, the purpose of the funding. It was primarily for infection controls in care homes. The home care sector was almost completely missing. And as Anna rightly said, it's a shared workforce. And usually people who work in care homes also work in home care. So you can imagine what is happening here. So that was really challenging and difficult to coordinate. Next one, please. So in terms of the two areas that we talked about, let's talk about compensating for added health risks. So hazard pay was not widely introduced. And as Anna mentioned, and Maya, that first it was only Scotland and Wales that introduced some form of hazard pay, and it was one-time payment for eligible workers. And then there was, towards the end of the first year, a second payment in Wales. Scotland did a pay rise for the majority of the care workforce, so it was seen as a way of compensating, but it wasn't really directly compensating. And then the last slide, just looking at the single site restrictions. Here, we didn't see any mandated single site restriction, although there has been some attempts. So it has been recommended in all 4 nations, Northern Ireland, Wales, Scotland, and England. And when we had the infection control fund in May 2020, there was a recommendation recommended restricting long-term care staff to 1 facility. Again, the focus was really on care homes. There was no mention of home care explicitly, and that was just recommended. And in September 2020, within the winter plan, there was a statement to limit all staff movement between settings unless absolutely necessary. And that was actually, faced with a huge restriction from the sector, because basically we have really chronic shortages of workers, and it was impossible to carry on the work safely if these restrictions in place. It was not practical at all. So when it comes to the DHSC, the Department of Health and Social Care, did a public consultation, and in November 2020 they decided not to put forward the restrictions to one side. Basically, the whole sector felt that even if it's something that desirable, it's really practically can never happen. And we've seen the effect of these pressures, and we're doing other studies in the workforce well-being and the financial well-being, and it's really had a huge impact. And in March 21, there has been more guidance to restrict, again, kind of guidelines, kind of recommendation to restrict workforce movement between care homes and other care settings. So we started to have some recognition that actually workers work across settings rather than between, just between care homes. And in England and Scotland, there has been some guidance in these documents on how the funding can be used, and it is left to kind of up to the employers in a way to help maintain normal wages of their staff, and the kind of may reclaim the cost of limiting staff movement. But again, it wasn't very detailed in terms of meeting certain levels of wages or compensating for full-time working, as we've seen, for example, in other places in Canada. So I'm going to stop here. I've already taken a long time just to, we can talk for hours on that. Yeah. Thank you.
Thanks, Shereen. Okay, Maude.
Hi, thanks. I'm just waiting for the slides to move on, but yes, next slide. So I just want to give a little bit of context. So Quebec is a second most populous province, 8.6 million. It has an aging population, actually, like faster than the rest of Canada. About 20% of the population was age 65 plus in 2020. The universal public health insurance covers healthcare provided in long-term care facilities, but it only covers partially for accommodation costs. It basically depends on people's revenues. So next slide. The governance is very centralized. So there's 18 socio-sanitary regions, but all the work conditions in public facilities are negotiated between unions and the provincial government. So everyone is paid the same across the board. It just depends on how long they've been practicing, basically. And long-term care facilities have been merged into these large healthcare organizations called CIS and CIUS, depending on whether they have a university affiliation. And so they're not independent, so they don't have a CEO or board, something that was considered problematic during the pandemic, and that has since been changed, at least for having a responsible for the facility. They still don't have a board or anything. They're still merged. Most of the healthcare facility, long-term care facilities are public. They're called CHSLDs. 59 are private, but they're operating under the same condition as the public ones. And then 43 are private. So those are really like unfunded, and they can charge whatever they want, and, but they're the minority. Prior to the pandemic, there was a report that documented the needs of care of residents in long-term care facilities, and apparently only 71% of these basic care needs were met because of staffing issues mainly. So next slide. We've talked about precarious conditions and low pay. I just sort of wanted to give a couple of data, a little bit of data on that. So only a third of employees were full-time. Only 36% stayed in their position for 5 years and over. For personal support workers, well, the wages were, so these are numbers like prior to pandemic, but varying between 20.5 and 23, well, $22 in public facilities. Private facilities typically just paid what was minimum wage, whatever is minimum wage. Back then was $13 an hour. And the burden has been increasing in terms of ratios of residents per nurse and residents per PSWs. During the midst of Montreal being a COVID hotspot in Canada and the long-term care sector sort of falling apart, the government realized that the sector had been understaffed and was missing about 10,000 PSWs. And so decided to develop and provide a paid 12-week training program to increase the staffing available for public long-term care facilities. So next slide. So this is a summary of the actual hazard pay. So in May and March 2020, the province entered declared a state of sanitary emergency. I think it was the first province to do so in Canada. And then following in between April and June 2020, they were governing by decree because it was a sanitary emergency. And so they implemented all these top-up policies, hazard pay for staff. These were all retroactive to March 13, 2020. So these details, so they're basically 8%, 4%, and sort of hourly cash top-ups for different types of employees, but they at various level affected pretty much everyone, public and private facilities. And these are like, these add up in the sense of like the $100 a week for people working in hot zones was on top of whatever they were receiving, 8% or 4%. So I know many provinces have lifted the state of sanitary emergency. Quebec has not. And one of the reasons for that is, or at least that the government says, is that because it implemented all these policies during the state of sanitary emergency without sort of negotiating with the unions. And the unions are quite powerful in terms of, wanting to have their say in working conditions. And so because all these things were not negotiated and not discussed with all the other political parties, if we lift the state of emergency, what happens is these should all disappear, which we don't want. So that's one of the reasons we're in the past few weeks, they have been trying to figure out, how to move forward with compensating people without compensating people. We're not really in an emergency anymore, but COVID is still there. And there's still issues in terms of staffing and shortages that are not specific to long-term care, but still in the long-term care sector. Next slide. So I just want to touch base on workforce mobility. There was no single site order implemented in Quebec. Most of it, and I've had discussion with the Ministry of Health because they figured it was not possible to do it. So they highly recommended it. And eventually they actually put in policies that were like, so that management had to authorize any mobility, and so that it would only be in exceptional cases to avoid service interruption. So really trying to change the mentality and culture about staff mobility, but yet without saying you can't do it because it's just not enforceable anyway. Next slide. So, but at the same time, they realized how important it would be to stabilize the healthcare workforce. So they created an exception register for labor mobility to examine how much of stability there was and how much movement there was, especially between hot and cold zones. They wanted to make managers accountable, so they required CO approval for that kind of mobility. Which applied to both private and public facilities. And they did observe a reduction in staff mobility from 25 to 5% between 2020 and 2021. So next slide. One of the, I think probably the best thing that happened over this, or sort of the best idea or strategy to stabilize the healthcare workforce was this training of 10,000 PSW. To fill the human resource gap in long-term care facilities. So they announced it in summer 2020. They started in summer 2020. They announced it in the spring. Recruited, I think they had over like 90,000 applicants. A lot of people had lost their jobs as well at that time. So they were offering a salary of at $26 an hour for new PSW. And during the training, there was a scholarship, which was equivalent to $21 per hour. So this was a 12-week training. And at the end, they were promised a full-time position in a long-term care facility at a $49,000 a year salary. So pretty successful. I mean, so far, like not 10,000, but 8,500 were trained and are still working, because I have to say, with that, in people trained, some people gave up in the process, but still, like so 8,500 are still working in long-term care facilities in Quebec. Next slide.
I think we actually have to wrap it up.
Yeah. All right. So I'm going to finish there.
Yeah, so I think, Adelina, you want us to finish? I'll stop sharing my screen.
Well, we've got a few more to come, and but we do need to come back to this topic, and I hope to see all of you again. Tomorrow morning we have, well, actually tomorrow we have 3 presentations in the morning also on long-term care workforce, and there then will be one in the afternoon, well, depending where you are in the world, but in the UK morning, and in the afternoon, including one from Shereen. I mean, this is one of the major topics, not just for the pandemic, but going forward. And very interesting to see that some strategies work better than others, like do something as opposed to do nothing seems to work. So very interesting study. Thank you very much. And that's sorry about this brutal comment, but I do think there's something in it. So thanks. You can find out more. You've seen the chat from the authors. I look forward to learning more. Again, we'd love to capture some of this learning also in the International Living Report. I think, as I said, workforce is one of the big problems that need addressing, and we'll get back to it. So thank you all.